Closes. The Oregon Health Authority will file a notice with the Secretary of State of these proposed rule changes in late October, and we will then publish the proposed rules in the Oregon Bulletin on November 1st, which will open the official public comment period that will run through November 18th. So there will be a public hearing on November 15th. More information to come on that as to exact time and room, although I anticipate it being in this exact room. As noted, that comment period will close on November 18th. The Health Authority will use the next period of time leading up into mid-December to process those comments that come in as well, to determine if there will be additional changes made to the rules, and those rules will be filed for an effective date of January 1st. As we begin and go around the room with introductions from people at the table and participants by phone, we'll ask at this time to make sure that everyone has their phone on mute or vibrate. We appreciate that. I do not anticipate that we will take a break during this meeting, so to that point, I would like to ask from the general public or members in the audience with us today if there is anyone that wishes to speak and offer public comment at the end. If you can state so and your name at this time, we would appreciate that. All right, hearing none. Yes?
Just a question. Where do the comments get sent?
The comments, thank you for that point of clarification, Bruce. For RAC participants, your comments will be sent to the CCO 2.0 rulemaking email address. That is the very same email address that you sent your request to participate in today's meeting in, and it is available on our RAC webpage for additional clarification. Thank you for bringing that to my attention. I did not hear anyone ask for public comment, so I do not anticipate we'll take a break, and at this time I do not believe that we will hear any public comment. I'd like to begin with introductions around the room. We will start to my right. Please state your name, the organization that you represent, and critically important, we implore upon you to use the microphone today. As we've learned through this process, it can be challenging for people on the phone participating to hear with any level of clarity, so please use the microphone. We may in fact ask you to repeat that comment if there's concern that others may not be able to hear it. And we will begin with introductions to my right.
Good morning. My name is Abdizir Mohammed. Work with the Oregon Health Authority of Survival and Inclusion. I manage the Tradition Health Worker Program.
Good morning. My name is Shelly Das. I'm the Equity and Policy Manager with the Office of Equity and Inclusion of OHA.
Good morning. My name is Melissa Hanks. I'm the Deputy Project Director for the CCO 2.0 project.
I am Julie Ernest with Oregon Health Authority. Athena Goldberg with All Care Health.
Jennifer Jensen, Lake County Traditional Health Worker Program Director.
I'm Iris Fitzler, Traditional Health Worker Program Supervisor at Cornerstone Community Housing. I'm a certified peer support specialist, community health worker, and been a doula for 23 years.
I'm Bruce Thompson from Mid-Valley Healthcare Advocates.
Good morning, I'm Mary Zadra from Northwest Family Services in Portland and in Salem, and I also serve on the OSHA board.
Robin Traver from Umpqua Health Alliance.
Carrie Trapp, Salem Health.
Suzanne Finnegan, Young Health CCO.
Troy Sonnen, Eastern Oregon Coordinated Care Organization.
Nancy Dubia with the Home Care Commission, Traditional Health Worker Supervisor, Coordinator, as well as representing the Commission, Traditional Health Worker Commission.
Allison Lowe with Pacific Source.
Jeremiah Rigsby with Care Oregon, that's Columbia Pacific, CCO, and Mexico.
Bill Bushka, IHN, CCO.
Janine Smart, Health Share of Oregon.
Lakeisha Dumas, Chair, Traditional Health Worker Commission, and Office of Consumer Engagement, Multnomah County Mental Health and Addiction Services Division. And I'm a certified recovery mentor, community health worker, adult mental health peer support specialist, adult addiction peer support specialist, and a peer wellness specialist.
I'm not as important as you said. My name is Tony Vesna. I'm the Executive Director of 4D Recovery. I'm on the board of MACBO. I'm a peer support specialist. I got a social work degree. And I serve on various other boards and commissions and advocacy organizations, all related to substance use disorder treatment and recovery.
I'm Angie Kuzma, and I am the Policy and Data Manager at the Oregon Community Health Workers Association. I'm on the Traditional Health Worker Commission, and I'm a CHW, or Community Health Worker with Portland Street Medicine.
Donnie Jardine with the Oregon Health Authority.
Kim Steubenrout with the Oregon Health Authority.
Thank you all. At this time, we're going to ask that Kim takes roll of RAC participants on the phone. Please, as she asks, please acknowledge your presence, and apologies if we were not able to capture names of everyone in the room, and if your name gets repeated here, please acknowledge your presence. Thank you.
Thank you. Joelle Archibald. Susan Bolt.
Here.
Carolyn Anderson. Amanda Cobb.
Here.
Kristen Downey.
Here.
Yetu. Okay, thank you. Emily Fanjoy. Ann Ford. Sarah Franklin.
Here.
Ariel Goranson.
Here.
Renee Hancock.
Present.
Jarrett Hefner. Paulette. Victoria Kelly.
I'm here.
Katrina McPherson.
Here.
Cammie Miller. Nancy Rickenbaugh.
I'm here.
Tim Rossell. Sandra Sampson.
Here.
Adrian Scavera.
Present.
Lindsay Staling.
Here.
And Nikki Terzdiff.
Yes, good morning.
Good morning. Don Wallace.
Yes.
And Stacy Whittington.
Here.
All right, thank you.
All right, thank you, Kim. So real quick, for those of you that have not participated in this process yet, just the way we will run these meetings is I will introduce each piece of this being a brand new rule. After each piece that is reviewed, I will ask for first in the room for a show of hands who wishes to speak to that particular section by offering comment or asking question. I will also engage people on the phone to ask just for name only, again, for RAC participants, seated RAC participants with us on the phone, just to say your name only to get into the queue to offer input or feedback or ask a question. From there, we will alternate between each rule section that we discussed. If the members on the phone will go first or in the room will go first. We're trying very hard to make this balanced and afford everyone on the phone the equal opportunity to participate. So with that said, we recognize that 410-141-3740, the new rule on traditional health workers, is being developed to implement Oregon Health Policy Board policy option number 6. That is to implement the recommendations of the Traditional Healthcare Commission, and you have some collateral information, I think, with you as well. Quick note, should have said this earlier, apologies. For those of you that are on the phone as general participants, you will be able to view this collateral information by going to our public meeting calendar, moving your cursor over today's date and this particular meeting. You will see a drop down that says Agenda. or documents available, click on that link, and that link will bring up all 3 of our documents, being the agenda and the 2 pieces of collateral information as well, for you to follow along with us. So here we go. Number 1. The authority seeks to ensure that all CCO members must have access to certified traditional health workers, THWs, who are part of the members' care team, to improve access to appropriate services and participate in processes affecting the members' care and services. THW is defined in Oregon Administrative Rule 410-180-0305. THW, and I apologize right there for that duplication of language. So we will pause right there. May I see first, by a show of hands in the room, anyone that wishes to speak to this first rule and or offer comment? All right, I'm seeing 3, 4 hands, 5 hands. May I ask quickly, just for individuals on the phone, seated RAC members only, just to state your name.
Sandy Sampson.
Thank you, Sandy. Anybody else? Let us actually then begin with Sandy on the phone, and then we will go to the room. Sandy, you have the floor.
Thank you. So I just need some clarification in regards to the CCO recommendation for CCO 2.0. Indian managed care entities, if that was established, is this going to be a requirement for tribal organizations?
Can I ask a qualifying question? If you are speaking of the potential formation of a tribal CCO, I'm just needing to seek clarification in your question if this rule would be applicable in that situation.
Correct.
I'm going to make the assumption yes, but I am reticent to speak to that with any absolute, as that process, I think, is still in development. I think it would be appropriate for us to probably address that offline, either through the tribal consultation process or as a one-off meeting with our tribal affairs folks. I just can't speak to that with certainty at this time. Is that okay, Sandy?
Yeah, because it just has to be fine, because in other RAC rulings, there's inclusive CCOs and managed care entities, so it's a little bit different. So I just wanted clarification in regards to the requirements.
Sure, and in full disclosure to you, I am not fully engaged in those discussions, so again, reluctant to speak in absolutes as to the implications for a tribal CCO. Mohammed
Thank you so much.
Sure. Mohammed or Shelley, would you like to provide any follow-up to that?
Sandy, I think the only thing I would just add would be working alongside close with Julie Johnson, who is the tribal liaison director for OHA. We're going to work close hand in hand with her to kind of coordinate if that needs to be aligned together. And so we would get back in terms of that, and we can follow up with Julie as well as with you as well.
All right, thank you for that. Let us start in the room again. Let us start on the right side of the room, and then we will work our way around, and then conversely next time we will start on the left side. So whomever on this side of the room wish to speak, again, please start with your name and organization. So, Bruce?
I'm Bruce Thompson, Mid-Valley Healthcare Advocates. The statement one, I think, would be made a little bit stronger to include words something like, in order to promote health equity, the authority seeks to ensure that all CCO members. So just that editorial comment.
Thank you for that feedback. We appreciate. And again, was anyone else on this side of the room that wished to participate? All right. And we will move to the other side of the room, and I think Angie or Tony, did you wish to speak?
Angie did.
Angie. And Angie, apologies. If whomever is on the phone that is not speaking could mute your phone, we would appreciate it. Thank you.
So this is Angie Kuzma. I have a couple of clarifying and then comments about number one. So it says it must have access to certified traditional health workers who are part of the member's care team. So first I'm wondering, does this mean that the members need access to all 5 worker types as part of their care team? I'm obviously in support of that. That'd be great. So would that mean then that, like, as part of the primary care home model, traditional health workers are part of that model? They're part of the care team. They're members of the care team. I would be in support of that as well. So just needing some clarity around that language. And then so I guess maybe could you respond to that, Mert?
Yes. So when we entail here, we mainly talk about traditional health workers, all of them, the 7 traditional health workers who are going to be involved as part of members' care team, depending wherever in terms of they become a member within the care team of either managed care or through whatever, but CCOs can actually be able to report on that, saying that we are integrating traditional health workers as part of member care team in whatever layers of that members would follow. But the intention is not one specific traditional health worker, but all traditional health workers across the board.
Okay, so I guess my recommendation would be to kind of spell out that this is if it's a requirement, saying it's a requirement of primary care homes to hire these worker types, because to me that's not really clear. And maybe spelling.
Hi, I'm sorry to interrupt on the phone. It's a little difficult to hear what folks are saying.
Sure, we will work on that and do the best we can, and if necessary, I will repeat questions when they are offered. Angie, can I ask you to perhaps repeat?
Sure. So I'm just noting that the sentence saying that the authority seeks to ensure that all CCO members must have access to certified THWs who are part of the member's care team, to me is not crystal clear as to whether or not it's a requirement that primary care integrates these workers as part of the model. Like, are these workers a part of the care team, and is it a requirement to hire them? Seeking to ensure. So I just think it needs clarity.
I have a question. Primary care, which primary care are you talking about? Are you talking about PCPCH, primary care, patient-centered primary care homes, or which?
I think that's what needs clarity in the language.
Okay.
What is the members' care team? What does that mean? That needs
So,
to be operationalized.
So I think for individuals on the phone, what we're hearing is a recommendation to potentially put some parameters around or define, for the purpose of this rule, what the members' care team is or what it consists of, and whether it does or not, by default, include the potential for THWs. Is that?
Yeah, as a requirement. And let me just give some background behind my comment here. I'm an appointed member of the Patient-Centered Primary Care Home Standards Advisory Committee. And a statement like this, I think if folks from that committee saw this, they would have some similar concerns and be like, whoa, this is, like, how do we integrate this, and how do we think about this in rural settings? And so when we think about, it just needs clarity.
Okay. Thank you for that comment. Okay, and Lakeisha, were you next? I'm sorry.
Did you have something? Yeah, I had a comment around.
And Lakeisha, I'm going to interrupt. Apologies. I'm going to ask again, benefit of everyone in the room on the phone, name and organization representing today.
Lakeisha Dumas, representing THW Commission and Multnomah County Mental Health and Addiction Services Division.
Thank you. Go ahead.
I just had a comment about defining and clarifying what access means, making sure it's just not a list of providers wherever, a pamphlet. And And if we're saying they're gonna be part of the members care team, maybe changing that to integrate into the members care team. I don't even know about primary care, them being located in there. I did that. I worked in primary care, and it only worked because I was through a community-based organization. But when the primary care, it was over-clinicalized, and it took away the value of traditional health workers. So maybe clarifying that and maybe saying integrate. No matter where you sit, you can still be part of the care team.
Okay. Lakeisha, thank you for that. For folks on the phone, to summarize, and Lakeisha, please, if I misstate this, please jump in. But in short, it was to define what access means and consideration of potential of including the word integrate in that definition so as to provide some level of clarity what the expectation would be on that multidisciplinary or care team. Is that a fair statement? All right, thank you. And could I ask folks as well in the room that are on this side that have, we've tried to put name tents, table tents up to help with process, to turn them just a little in this direction. Thank you so much. Janine Smart from Health Share of Oregon, please. Thank you.
Janine, Health Share of Oregon. A couple of things. One, building on what Lakeisha said, I think that it's important to note the importance not only of clinic-based traditional health workers, but also community-based is really important. And then additionally, I think noting that there might be need for prioritization of members. Everybody may not need a traditional health worker, and there's not capacity across the state for everyone to have a community or a traditional health worker. And so trying to figure out how we're going to prioritize who needs them, who doesn't, who's able to access them, whether it's clinic-based or community-based, would be really helpful.
Thank you for that comment. Mohammed and/or Shelley, would you like to?
I think not further additional comment beyond stating that we're not typically asking like everyone in the state should have a traditional health worker one-on-one. But if there's a need for services by a member that a CCO provided services to, and that services rendering involves traditional health workers, then the CCO should make that service accessible and available for the member using the traditional health worker.
Which makes sense. That's not what this reads here.
Okay, and thank you for that comment.
We will
appreciate
that.
All right, staying on this side of the room, did I see Jeremiah?
Jeremiah Kilburn, Columbia Pacific. Ralph, did you say you wanted comments at this point on the first part of this rule or the whole rule?
Just number one. We're going
to.
All right, thank you. And staying on that side of the room, is there anyone else wishing to speak? All right, let me do a quick check-in on the phone, give another opportunity for anyone based on comments that were already submitted or feedback provided. Would anyone else, seated RAC member, like to speak specifically to what is addressed in number one? All right, last chance, anyone in the room to speak to number one?
One more thing.
And name, please.
Actually, maybe two. So I'm wondering also whether, if people aren't connected to a primary care home, we know that everybody who's a member isn't necessarily connected to the health system. Would this speak to members being able to access if they don't have a primary care home?
I think what you kind of more go into like the little details, the nitty-gritty of how CCOs provide services to members. The intent here is if a member within the CCO's network do need a services, whether it's in a clinical setting or through a community-based setting, then CCOs providing that services to that member. And if that services rendering involves a traditional health workers being part of that, that is the intent here. And so then how they do that, that is the job of the CCOs. We don't get to dictate how you render that. As far as you ensuring that members who really need that services to access THWs, the CCOs are providing that opportunity for the members to have that.
All right, thank you. And Angela again. Pass the mic. Thank you.
This ran out of red. Okay, this is Angie Kuzma from the Oregon Community Health Workers Association. One more time, just wanted to state, like, for the record, I would, if you're going to be coordinating with the PCPCH Standards Advisory Committee or that program, I would be in full support of traditional health workers being integrated into that model, and for them to be fully integrated into primary care. But to echo what some of my colleagues have stated, that directly hiring is one way to do it, but probably not the best way, because I agree that they've been over-clinicalized under that model, and I would be promoting contracting with kind of community-based organizations, and I think peer-run organizations, certainly ORCHWA and other like doula associations can provide support of how to do that, and we know best on how to do that.
All right, Angie, thank you for that comment. All right, appreciate. And I'm seeing one more person wishing to engage. We'll recognize Iris.
This is Iris Bixler with Cornerstone Community Housing. I just wanted some clarification around this piece that says to improve access to appropriate services and participate in processes affecting the members' care and services. Could someone just address that piece of that statement?
So, well, that, I think, depending, like, let me throw back. So what do you need clarification on? That's not clear in terms of when we say access in terms of appropriate services, generally means all the services that traditional health workers will be providing to the member, and then participate in process affecting the member's care team. Then generally means allowing the traditional health worker being part of that process in terms of participating and delivering of, the care with the member, so that it's not just either one-on-one with the member, but if a THW is involved in that delivery of care, they are well informed in that process as well, making sure that the delivery of care that the members are receiving, they are part of that, affecting the process. So that's what it just entails to. And for further clarity on that, specifically that's something that came up from the commission letter. So.
I just want to, this is Iris again, I just want to be clear that the access to traditional health workers the point isn't to improve access to appropriate services.
Right.
So whatever language we end up with at the end of this, I just want to make sure that what you're saying isn't that traditional health workers' job is to improve access to other services. They are the service in this scenario.
Thank you.
Thanks for the comment.
Appreciate that comment. Let me, Tony, let me just pause for a quick moment. We want to make sure that we give people on the phone the opportunity, as we did a second round here, and I think I did hear someone wish to engage. Can I just hear by a name only who that was?
Lindsay Staling.
Lindsay, and was there anyone else on the phone that wishes to engage on this? All right, Lindsay from Mosaic Medical, you have the floor.
I would just like to comment that at present, it's a hard lift to get all traditional health workers, community health workers certified, because the certification requirements are so broad and encompassing multiple types of both clinic-based and community-based individuals. And we have a robust community health worker program that we've had for 12 years, but we have not pursued certification due to both costs and training priorities, and the fact that because we're a clinic-based entity, it does not, it would be a very significant time difficulty to onboard in the way that is necessary as outlined by the Traditional Health Worker Commission at this time. So I worry about including the language of certified while also having so many requirements to get someone certified in terms of hours, but also financially if you are not already an approved training location. And I think that could be a burden in getting this off the ground.
Thank you for the comment.
All right, quick show of hands again. We're going to go to Tony and Lakeisha, and then I'm going to do one last round for show of hands at this time on this one before we move along. So anyone other than Tony and Lakeisha? Tony and Angie. Tony, Lakeisha, I apologize. All right. Tony, go ahead.
Yes, so this is
And
going
Rob,
back
okay.
to Iris's point. And so I think that the intention of the sentence here is to get THWs to be a part of the care team, and that the improvement to appropriate services could be a benefit of having THWs on the team, but not the purpose. And so if I was a business and I was reading this, I would be thinking, okay, THWs have to be on part of the care team to improve access to appropriate services, when that's not really what they're doing. It could be a residual benefit of that. And so I think that you could probably scratch that to improve access to appropriate services and just have it read who are part of the members' care team and participate in the process affecting the members' care and services. So I think the intent is really about access and participation.
All right, Tony, thank you for that. We appreciate. Lakeisha and then Robin Traver.
Lakeisha Humans, Traditional Health Worker Commission in Multnomah County. For that sentence, I kind of like the way it reads. When you have a traditional health worker, you do improve the access to appropriate services, because our relationships with like housing and just different things, we have a better access to these services. I can see it, but depending on how you interpret it, so maybe refining it, but I kind of like the way it reads. That, and I'm just wondering if there should be a time frame, or is that in a different part? Like they should have access to a traditional health worker within 90 days. So I don't know if it sits in there or somewhere else.
Okay, thank you for that comment. I'm going to recognize Robin Traver from Umpqua. Angie Kuzma from the Community Health Worker Association is asked to engage, and then I'm going to move us along on this, noting again that everyone, as a seated RAC member, does have opportunity to provide additional comment in writing within the next 7 days. Robin.
Robin Traver from Umpqua Health Alliance, CCO, serving Douglas County. I just wanted to comment on the certified piece and just comment on the challenge of getting certified traditional health workers in Douglas County and some of the smaller rural communities, because we just don't have the workforce there. So I think we would like to request guidance potentially from OHA and how to get those resources. Maybe this could be part of a transformational center initiative, something along those lines. It might be out of the scope of the RAC meeting, but I just wanted to acknowledge that.
No, appreciate that and appreciate the recommendation. We will absolutely take that under advisement and recognize that I think both you and the individual from Bend, your comments are in pretty much alignment there, and I think others made as the challenge in rural area. Real quick, I will offer Shelley and or Mohammed opportunity to respond to that, and then we'll have our last piece on this.
I think the only piece regarding certified, that is a requirement by CMS as a state agency. We cannot just regarding Medicaid dollars, it has to be certified. Someone certified by state in order for them to deliver services to a member. And that's a rules requirement from Center for Medicaid Services, that we have to be certifying people as a state agency.
All right, we will recognize Angie.
This is Angie Kuzma from the Oregon Community Health Workers Association. Just if I could quickly respond to some of the concerns about the workforce and training.
Sure. Angie, I am going to ask that comments and feedback be limited to specifically to the relevance of the rule and its applicability. So,
okay, I had one about that as well.
Okay, thank you.
Just about the rest of the sentence, like the purpose of number one. I think it would be great to see it just say to improve access to appropriate services, yada yada. To address the social determinants of health and improve health equity.
Thank you for that comment. I appreciate it. All right, I'm going to move us along. The next segment that we are going to take will be 2A, and then we will get to 2B after. So I will, as this is a new rule, I will read this aloud in its entirety. Number 2, CCOs shall develop and implement a plan for integrating and using traditional health workers in accordance with this rule and the CCO contract. A, THW integration and utilization plan shall include information on THW access and usage for CCO members, membership measurement standards and benchmarks, and lastly, evaluation of the CCO's progress in reaching those benchmarks. May I get, by a show of hands, individuals in the room wishing to speak to that? I'm seeing 1, 2, 3, 4, 5 hands. Can I get a check-in name only on the phone if you wish to engage on this?
Nancy Rickenbaugh.
Thank you, Nancy.
Sandy Sampson.
Nancy and Sandy. Anybody else? All right, we're going to start in the room this time. Let's recognize Jeremiah Rigsby from CARE Oregon first. And Bill Busca, whomever.
Jeremiah Rigsby, CARE Oregon, Columbia Pacific, and Jackson Care Connect. I think first of all, I would say that our CCOs do want to work closely with the Traditional Health Workers Commission to figure out how we incorporate community health workers and traditional health workers in a real way. But looking at A through C, there's a way we can do this quickly, and there's a way that I think we can do this authentically and right. And it kind of comes down to when you would want this plan to materialize and how fast you want this plan to materialize. I don't want to necessarily box this into an unrealistic time limit, but it's going to take, to do this right, it's going to take time to figure out what measures or standards and benchmarks should be for work that we really haven't done in an integrated way. It's, much less coming up with an evaluation of how well we're doing on those measures and benchmarks that we haven't set up yet. So just say that I think this can be done well, but I wonder if we should think about when, or maybe it's a question when the agency would expect these plans to come back. I would just say I noted in the contract that it looks like April 15th is a date they're using, which is, I mean, there's a way we can do that, just won't be good. It's kind of, yeah.
Thank you for your question, Jeremiah.
Yeah, just pull it a little closer, Shelley.
So we are actually thinking about changing the submission of the plan to November, not in April. So November of each year, you will be submitting the plan. And then April of each year, the CCOs will be submitting the other reporting requirements, the data points that we would like them to submit about integration and utilization, focused on integration and utilization. That reporting template was there with the RFA, and you all have seen it when you submitted your application. And so that's why we are making that gap between the submission of the reporting template and the plan, so that based on your data, you can develop the next year's plan.
And if we can stay at that end of the room, and then we will circle around either Bill Busca or Dr. Little. Did you wish to? No, okay.
This is a question about B, measurement standards and benchmarks. Is the intention that each CCO will develop its own measurement benchmarks and standards, and then so we'll have 15 different disparate measurements and benchmarks and standards that will be very confusing? Mm-hmm. Or is the idea to have one? Just some clarification on that.
The intent is to have like one measurement standards that we would be using. The typical one we kind of started with, and we were going to use our quality and metrics team to kind of like have a measurement standard across the board. And so the one that we kind of wanted to start off is like the reporting template as a measurement tool for now, that in a way that they would be able to measure and use that as to see how CCOs are, in the end, making the benchmark of the integration and utilization plan. And so that is the intent, so that there's like one reporting that rather than having randomly, we do acknowledge as a state agency, there are various programs within the state that requires reporting from CCOs, so we want to be just having one standard reporting, so you would be able to use that across the board to report on that, whether you are meeting your goals in terms of integration and utilization.
And can we continue to work our way around this side of the table by show of hands? Was there anyone before Robin wishing to speak? And then we'll work our way back this way. Okay, Robin.
Robin Traver from Umpqua Health Alliance. Just to clarify and follow up on that last piece, measurement standards and benchmarks. Am I hearing correctly that these have already been established by the OHA and this was included in the RFA?
Mm-hmm. The reporting template is what we're using for measurement in terms of how you integrate and utilization, yeah. Okay. And it's been with the RFA.
Okay, thank you.
And
I'm sorry, I didn't hear what Mohammed said.
Sure.
Can you repeat that?
Yeah, and what I said was the measurements tools what we deployed out was with the RFA, and we released the RFA to all CCOs. So it is the minimum reporting template that we use with the RFA.
All right, we're going to stay on this side of the room. I think Bruce Thompson and then Iris Bixler, and then we'll continue around, and then we will get to Nancy and Sandy.
So partly in response to Bill's question, but regarding 2a, so the integration and utilization plans shall include, and maybe you're already doing this, but perhaps spelling it out will be helpful, shall include local community-based organizations, including local public health associations who may already be providing THW services. And the idea here is so that a CCO is not duplicating a service that might be already provided in some communities, as it is already being provided in some communities, and then the CCO becomes a competitor for that local community provision of those services. So the notion would be that in developing the integration and utilization plans, engaging with local community-based organizations, including local public health organizations when they're available. Obviously, they're not going to be available in all communities. To Bill's point about measurement standards and benchmarks, perhaps it would clarify it to say, the rule would say measurement standards and benchmarks in conjunction with I'm sorry, I might be saying that wrong. Is it ORCA? ORCHWA, okay. So measurement standards and benchmarks in conjunction with ORCHWA and the Office of Equity and Inclusion. So again, incorporating these measurements and benchmarks based on the findings and the knowledge of an organization such as ORCHWA.
So I think to respond to the plan piece, we did, like each CCO, based on the current RFA submission, that they did present a plan already in place. And we do always encourage that. We don't see CCOs as this one silo agency like sitting out there and doing overall our health systems alone. That community-based social service agents and everyone else would be involved with that plan to support the CCOs meet these goals collectively and collaboratively. So that is the intent of the plan, that it would be both a collaborative effort of having county health and many other institutions as part of that overall supporting a better integration and addressing holistic health. And then regarding the measurement standard piece and benchmarks, we won't be able to include OCHWA because OCHWA is like one organization that only represents community health workers. Right. So these THWs is across all traditional health workers, 7 workforce. So the reporting and measurements would affect everyone across the board, so we will not be including one organization as a way to kind of help us or address benchmarks or standards. So that is one thing. Thanks.
I appreciate that clarification. I would just make the point that perhaps clarifying that in the rule will leave it less open to interpretation among 15 different CCOs.
Gotcha. Bruce, thank you for that comment. Appreciate it.
Is it possible to put a microphone directly in front of Mohammed?
All right, there it is.
There is. In fact, I'm going to swap seats with Mohammed so that he's closer to the microphone, and we will work to do that. Do you want to summarize? Are you okay? Okay. All right. We're going to recognize Iris Bixler.
Yes, this is Iris with Cornerstone Community Housing. I just wanted to ask a clarifying question as part of the Traditional Health Worker Commission. It's my understanding that at our next meeting, agenda item is to look over these measurements and standard benchmarks. So, Mohammed, could you clarify whether the measurements and standards benchmarks have been set in stone, or whether those are going to be addressed at the commission meeting and potentially reworked?
We only submitted it with the rule, with the RFA to have something handy, but we would have a revised version of thorough measurement standard with the minimum reporting that may be even less, more cumbersome than it's this right now, like getting so much feedback and suggestions from all the different workforce, including even CCOs, to help inform and shape that what would that a better reporting benchmark would look like in terms of measurement. And so then we would have that available once the rule is, once the contract is kicking as effective, then it would be available by that time only. Thanks.
All right, and let us continue along this side of the table by show of hands who's still. Okay, Angie, and then who else? I'm sorry, just want to capture. All right. Get Angie a microphone, please. Thank you.
This is Angie from Orchwa. Thank you, Bruce, for your comment. I just want to echo that and say I think that this should clearly spell out that in participating or collaborating with the Traditional Health Worker Commission or other peer-run organizations or Orchwa or organizations that are run by traditional health workers for guidance and advice, and in fact having traditional health workers themselves participate at all levels of the planning it and implementing it should be spelled out in here if possible.
Thank you for that comment.
Sure.
Did you want to?
Yes. Yes, in the contract, actually, it has been spelled out that the CCOs have to discuss and consult with the THW Commission in every step of the way when they are developing or implementing the integration and utilization plan through the THW liaison. And so it will be much more detailed in the contract itself than the rules. And also, I think after hearing all of you, I think we will be considering including the definition of THW and its work and the categories of THWs that are currently in the workforce.
Sorry, really quickly, the rules, I think that it's fine. I think if we could really restate even if it's already in the contract, this is where we sort of hit people over the head with it, right? Like it's where it's all spelled out. This is like the final, this is where it's really explained, right? So, thank you.
Okay, and we're going to clarify that hitting people over the head is a figure of speech. With
figure of speech,
I do want to
it's where we clarify everything.
Correct.
Right?
Thank you for that comment. We do appreciate it. I'm going to go to Nancy Rickenbaugh, and then on the phone, and then Sandy from Yellow Hawk. Nancy?
Hey, Ralph, my questions were answered.
Thank you. Sandy?
Yes, this is in regards to 410-180-0350, where they included oral health training requirements within the traditional health worker. I think it was last year. So I guess what I'd like clarification on is it says information on traditional health worker access and usage of CCO members. So each CCO member or organization, a CCO organization, say for instance in Umatilla County and this side of the state we have only EOCCO. So the requirement would be that EOCCO have traditional health workers in all categories of services that they provide. I guess I'm not sure, because you've got doulas, you've got all these different traditional health workers according to the training requirements, and I just want clarification. Do I have to have a peer support specialist in alcohol and drug and mental health, family services for different members, or is it just one traditional health worker, or you have to actually bring on all these other additional services for that CCO?
Sandy, this is Mohammed. If you can hear me, I think in response to that, as the services need arises, we do anticipate that all traditional health workers would be used, generally all of them, depending on what kind of services that the specific traditional health worker offer. So a community health worker may not be doing addiction counseling work. That would mean you're going to use the right traditional health workers for that work. The work for a doula is out there. The work for a patient's health navigator is out there. So whatever as the service need arises, then CCOs would be able to use that to integrate and bring traditional health workers involved in it.
And additional. Just as we have gone around the room and given people ample opportunity, I just want to make sure, is there anyone else seated RAC member on the phone that wishes to engage on this? All right, last pass in the room by show of hands. Anyone wishing to speak based on responses given so far or comments submitted? All right, seeing or hearing none. 2B, and again we will read this piece in its entirety. CCO shall develop and implement a plan for integrating and utilizing THWs in accordance with rule and contract. Sub B, THW integration and utilization plan shall be submitted to OHA as required under the contract. And I see by a show of hands in the room anyone wishing to speak to or ask questions about this requirement, proposed requirement. Seeing none. Any on the phone wishing to speak to this particular subpoint? All right, hearing none. We will read out loud number 3 and open for the same process. CCO shall establish, based on recommendations and standards issued by the Traditional Health Worker Commission, a payment model grid that defines sustainable THW payment levels and alternative payment strategies. The CCO shall make this payment model grid publicly available. May I see by a show of hands in the room first of individuals wishing to engage? May I get just by name only individuals on the phone that may wish to speak or engage on this?
Lindsay Staley.
So Lindsay and Nancy. All right. I'm going to ask, and I apologize, I cannot see your name, the woman past Dr. Little. Let me acknowledge you first, and then we'll go to Allison.
Red is
and
on.
I'm going to ask individual on mute, or that is typing, if you could go on mute until we ask you to engage. Thank you.
My question was, does that imply that every CCO will have their own payment method? Or is it going to be one general one for every CCO to utilize?
And Mohammed, can I ask you to repeat her question for the benefit of everyone on the phone?
The question was regarding the payment model. Does that mean each CCO has to have its own payment model grid, or is there a unified payment model grid that CCOs will use across the board? And to answer here is that we did provide the payment model grid as a guide. But in terms of payment, then it would be the responsibility of CCOs to really provide a payment, and then it's a sustainable payment that THWs would be able to use. And the payment grid is a guide for the CCOs. We wouldn't impose them to use one across the board, but to use that as a guide and then pay all the traditional health workers within their network through that payment system.
Okay. Jeremiah, if we can stay on that side of the room just to recognize those that had their hands up first. Allison?
Mine is just a question. When will those be available, those recommendations from the Commission?
The payment model grid is ready and readily available, and so it would be publicly posted on our website where CCOs will be able to access.
And is it posted there now?
It is, no, but it's one of the documents. We would have it by September 30th. We are anticipating to submit these to our general and then have it by contract date. There will be something available for all CCOs.
So just to repeat that for everyone on the phone, the draft will post on September 30th, or can you, I want to make sure everyone is certain on what that date of posting will be and what that document will be. Sorry, please repeat that, Mohammed.
What I meant was the payment model grid would be available publicly by September 30th. So generally October 1st, when CCOs needs and many other documentation the OHA will be providing, including the reporting templates, we anticipate all that will be publicly available and accessible for CCOs to use.
Okay, and then Jeremiah, and we'll continue around the room this direction.
Jeremiah Bixby with Carolyn Pacific and JCC. I think we understand the intent to make sure that traditional health workers are sustainably paid. And there's a couple of issues here, I think.
Can't hear him.
I think number one is that we don't publish any of our payment models. So we're protected by trade secret. So if we put our providers into alternative payment methodologies and we talk about the rates for paying them, that's not available to the public, number one. I think number two, there's a tension between the fact that CCOs have time-limited contracts, and this is really looking for sustainable payment for providers. And so, and the fact that CCOs are supposed to be community-based, you would want to put your traditional health workers in payment models that address the needs of the community based on what we're seeing, not based on this idea of sustainability, regardless of what is needed in the community. And so I want to call out the fact, I think we all want to make sure that our providers are paid stable rates. We're in Medicaid, and that is often means that we don't pay providers rates that they're happy with. So this idea of sustainability in Medicaid is one that's already controversial, and you're adding in traditional health workers. We should be aware of that. We pay providers much less than what they make in the commercial market. And then second, that this idea of long-term payments, I think we want to get into long-term partnerships with traditional health workers. I don't know if that's appropriate for statute at all, based on us needing to adapt to the needs of the community.
Thanks for the comment. And regarding, I think, the publication of this, that would be something our DOJ folks would be responding to it. If that is legal and legit for that, OHA would require CCOs to publicly post their payment grid publicly. And then I think regarding this other, I know it was a long comment, but it's being noted that regarding sustainable payment, we're not talking here like the one-year contracts some CCOs have for now, but we talk about this is a 5 years contract that we do require. That what is stake here for the state is, don't want to get in deeper into that, but it's a $6 billion taxpayers that OHA is providing to CCOs. And then 10th is how do we overhaul a robust, access to care and improve, which many CCOs were not able to. So in summary, we're intending that a longer term, well-embedded, integrated overall care of holistic health, that THWs are part of that, making sure that organ consumers do get the better care, lower cost, and high quality care. That's the intent. Thank you.
So we'll give Jeremiah one more opportunity for follow-up there, but also we'll recognize the importance of what the matter that he's bringing to attention related to trade secrets, and we certainly will consult with the Oregon Department of Justice on that. But go ahead.
Yes, we understand that the contract is a giant contract, and we are very aware of what consumers and taxpayers, I think, expect, and that is the tension. If you are going to ask us to provide quality care, provide access to care, but also to do that triple aim while bringing down costs, 5-year contracts that may not align with what the community needs are really appropriate. That's the point.
Thank you. We appreciate that comment. Staying on this side of the room, who wish to speak as we come around? Okay. We'll recognize Angie.
This is Angie from the Oregon Community Health Workers Association. Okay, so there's a lot going on in this one. And just some context, I'm the chair of the Payment Model Subcommittee on the Traditional Health Worker Commission, and I've worked on this exact grid of which we speak right now for a long time, since 2016, actually. So I don't think that it's CCOs that should be publishing or like establishing, as it's put in this this number here, this grid. I think OHA should be posting one grid that's just public information for whoever wants to see it. This grid that we've been working on, and it's pretty much, it is done. And this grid just summarizes what we already know about the different ways traditional health workers are being paid or have been paid in the past. And just as a caution, there's a lot of nuance that this grid doesn't really capture, and it's not recommendations for these are great ways to pay for traditional health workers. It's just what we know has been done. Because there's always this big question mark of like, well, how do we pay for traditional health workers? And we just went out and tried to answer that question of how it's been done. What this grid doesn't capture are some emerging payment models that are being explored by our subcommittee right now. And we're actually in the process of starting to write a policy paper with some staff from OHA proposing a new payment model, value-based payment model for at least the services of community health workers. I'm exploring and to seeing if there are other worker types who want to join in on this, but we're going to be presenting it to CMS to see if we can figure out a different way to pay for the services of community health workers and possibly other workers. That's not reflected in this grid at all. So I'm just thinking that this needs a lot of revision, and it shouldn't be the CCOs who are publishing it. It should be in one place, and just as information, not recommendations.
Thanks for the comment. I think in regards to the area where it is mentioned, the CCO shall make this payment model publicly available. That's something that we would be, the intent was in terms of accountability to ensure that it's not just, we are paying, but how and what payments methods are you using to pay? We're not asking you, I'm paying them, $20 an hour. That's not the intent here. The intent is we are paying, and these are the ways we are paying for traditional health workers. Very simple public information that would be available, that can be reported, as well as any public can see. That's the whole intent here. Thanks for the comment.
And I get by show of hands again on this side of the room who wish to speak. Let's recognize Bruce Thompson from Mid-Valley Healthcare Advocates. And then if I can just say, Lindsay and Nancy, we will go to you directly next on the phone.
This is Bruce Thompson, Mid-Valley Healthcare Advocates. This is a very important discussion regarding what is public information. It has to do with accountability. You are correct. I agree with you completely. And transparency. And the more accountable OHA is and the more transparent OHA and CCOs are, the more acceptable CCOs will become over time. That's my editorial comment.
Thank you.
Thank you for the comment. Okay, let's go to Lindsay from Mosaic Medical, and then we'll go to Nancy Rickenbach. Lindsay, go ahead.
Thank you. I would just like to comment that typically we're recruiting individuals from often the same populations that many of the community-based or health entities are serving. And by that I mean that these tend to be individuals who maybe don't have advanced degrees, who maybe are in a shared lived experience with the target populations, and therefore I want to make sure that we are creating payment models that allow them to rise up out of poverty, if should that be the circumstance that they are living in, and that these payment models also account for the ongoing training fees or the upfront training fees that many community-based or healthcare entities would shoulder. And so I think that that is a little bit different than what we do when we are looking at how we might pay for nursing or provider level services. And so I really want to advocate for payment that reflects their skills and expertise, but also does not force them to stay within the same level that they may be struggling at, and allow them to live and work in the communities that we want them serving to help others.
Thank you for the comment.
Thank you for the comment. Let's go to Nancy on the phone.
Hi, Ralph. This is Nancy Rickenbauer, Willamette Valley. My comment would mirror what Jeremiah's comments were on the fact that we don't publish these because they are trade secrets. However, if the state has something to publish and the CCOs all are required to do that, I'm not sure why the CCOs would need to post it versus the state posting it. And we and the CCOs, you know, have to pay at least that or use the same payment methodologies as recommendations in our development of that. We have a lot in our area, but it's nothing that we would post and say, hey, here's how we pay you. So I'm just concerned on that piece, you know, what else will we post next? I just think it's the wrong place to have it in rule.
Thank you.
Thank you for that feedback. Obviously, there are a lot of folks interested in this particular section. We are doing fine on time for the length of this meeting. I don't want to cut it short without giving this the opportunity for the conversation it warrants. With that said, is there anyone else in the room or on the phone, in the room first by show of hands, on the phone, name only, that does wish to engage on this? All right, I'm going to work this in, go to Bill Buska, and then we'll go to Tony and Angie again.
Bill Bushko with IHN. Now I'm really confused about what this payment model grid is. If it's not amounts of how much we pay, which we've already said probably will be difficult to do. We don't post. If it's just about the methods, we use value-based payments, we use alternative payment methodologies. It'll be 2-sentence grid. And it won't be any useful information. So I'm just not quite sure what the value of it is. I mean, I don't mean to be a dead horse, but I really don't see the value.
Bill, I think like you stated, the intent here is to use that as a guide on however you pay THWs. But the calling language here is sustainable. It's not like we issue one-time grant, 1 year and we are done, and then you don't have a 0 THW even in your whole CCO. That is why this whole notion of sustainable payment, generally going back to the prior rule, integration and utilization as part of a team is not, a 1 year thing. It is like consumers are always there needing mental health addiction services, other social services that THWs are involved. Then with them playing that role, as far as you have this contract, they are part of that care team supporting that effort, and you are helping support to pay them like any other providers. But however you pay is a matter of a choice that CCOs has. This payment model grid is just a guiding document for you to use. And if you use even value-based payment, then what the current payment model does not show, it's like you sharing like that, like saying we paying like this, and then the intent is ultimately a sustainable one that's embedded within the CCO.
Jeremiah, I'm going to pause because these two folks at this end have asked, and then we'll circle back to you. So first we'll do Tony, then Angie, and then back to Jeremiah.
Yes, so I think...
And Tony, I'm going to ask again, name
Tony,
and organization,
Tony
please.
From Fourth Dimension Recovery Center.
Thank you.
So I think the payment model grid is useful from a provider's perspective and to ensure fidelity of the service. So the last thing that we really want to do as a health authority is to say, okay, THWs work. There's lots of different kinds of THWs, and their practices typically fall outside of general medical models. And so what we don't want to do is have this massive investment in a new workforce that actually works to accomplish some of our goals, right? And then we just throw the service delivery inside of a concept that doesn't allow for authentic service delivery. Does that make sense? And so I think the payment models are a guide to help ensure fidelity, of service delivery. But if we onboard a bunch of peer mentors throughout the system and all they do is junior counseling, then we've done nothing to transform the system. And currently, on the SUD side, we have some of the highest rates of abuse and the lowest rates of access to recovery. We have a ton of people dying, and then we have a huge burden on all of our systems. And so I think the intention is to innovate the system, and peers can be an instrument to do that. And the only way that innovation is going to work is through intentional payment methodologies. And so this is a really critical component to having an operationalized THW workforce that is effective and authentic. So, it does need time and energy put towards it.
All right, thank you, Tony. We'll recognize Angie.
This is Angie with the Oregon Community Health Workers Association. Totally agree with what you just said, Tony. How you pay for the services of traditional health workers really matters. For example, if you're going to try to pay for services of peers with a fee-for-service model, that is not going to work. There are some codes you could potentially one day use for community health workers. You could use a fee-for-service model. Not going to work. You're going to end up paying for just a small sliver of that amazing workforce's huge scope of practice, and you're going to end up totally destroying the fidelity of the model. And then grants. Most of these workforces are being funded by time-limited grants, which interrupts the longevity and the continuity of that role, being able to work with populations for long periods of time and work on long-term, upstream, community-level issues that affect their health, social determinants of health. And so, those are the things we're trying to get away from. And so if you are able to share, the ways that you're paying for traditional health workers, you don't have to tell us how much or like dollars and cents and stuff, just the model, that is really useful to us. So, thanks.
All right, thank you for that comment. We're going to go to Jeremiah. Can I just get a show of hands in the room who else wishes to engage? So after Jeremiah, we'll recognize Mary Zedro from
Northwest Family Services.
Northwest Family Services. Jeremiah.
Yeah, for Jeremiah with your Oregon, I think actually it sounds like we're on the same page about the need for innovative payment models for traditional health workers and authentic payment systems to actually pay people for the work that they are doing. I would say two things. In our experience with people care leaving in the metro area, we had a lot of conversations with providers about the rates that we pay in the healthcare side of things. Our providers who we think those rates are sustainable, our providers are with us, but when we had other providers coming from a different CCO, they didn't think those rates were sustainable. There's a fundamental disagreement over what sustainable means. And I think what you're hearing from, at least from me, is a hesitancy to put something in the statute that has such a subjective meaning, and is not, to be honest with you, in Canada, is not completely in the CCO's control. What makes a business sustainable, what makes an employee sustainable if we aren't directly employing them, isn't necessarily dependent completely on the CCO. So I think being vulnerable to that is something that we have a bit of concern over. And then the second thing about sustainability and 5-year contracts, I think one of the things that this presumes, like everybody at this table does, I think, work in the community and is starting to build infrastructure that we can rely on, but that is not 100% time the case. Sometimes we make investments, and we're going through this now, in a community-based organization to do traditional health work, to do certain innovative work, and that organization struggles halfway through the contract. And we are on the hook for that. you know, and so locking yourself into something with businesses and entities that you're trusting and you're hoping work out well for sustainable reasons, but you may have to retrench, you may have to rebuild, you may have to go into the community and find a different solution if something doesn't work out. That happens for us often. And so that's what I'm saying. Traditional, I think this work, which is innovative, is important, but as opposed to saying you have to be locked into these sustainable contracts forever, regardless of whether or not that works for the community, that's what I'm saying is sometimes inappropriate based on our experience.
Well, I think.
Tony, I'm going to ask that you respect the process that Mary will be speaking next. Thank you. Yeah, and we'll give Mohammed opportunity to respond to Jeremiah's comment. I'm seeing another hand in the room. So let's have Mohammed respond, and then Mary will have opportunity.
I think in summary, when we talk about payment and why are we saying sustainable, the intent has been for the last prior 5 years when CCOs had contract, out of 16 or out of 15, what we have seen is maybe 4 CCOs just integrated traditional health workers across the spectrum. Where were the other 11? They were in the system. And so this is answering to that, like holistically, collaboratively, how can we do a better job? When we're talking about holistic health, we integrate, we bring everybody on board. And the intent of this was, when it comes to payment, we're not dictating the sense the pennies you pay, but we're saying pay the traditional health workers as you stated, integrating them into the system and delivery of care. Then they are part of that, and how do you ensure they continue to be part of that? Not then, you hire them 1 year, and then they're all long gone. And then the issues of mental health, all this will never goes away. It's still within the organ consumers, it's still within the system. And so that we are saying holistically, collaboratively, find a way to pay for that services throughout the 5 years contract you have, but you are sustaining everyone across the board, from the provider to the traditional health workers, everyone in between, collaboratively to serve the organ average consumer better, for better quality and better care.
Thank you, Mohammed. We're going to go to Mary, and then I apologize, I cannot see your name, Tent, at the end of the... Netu, thank you. We're going to go to Mary, and then Zetu, and then we're going to ask Tony, I think, wants to get back in this, and then I will likely move us along. There you go.
Thank you. Mary Zadro, Northwest Family Services, and also ORSHA board member. Mohammed, I have a question for you. Did you say that DOJ may need to clarify if the CHW grid would be considered a CCO priority information, like the rate payments?
No, what I was responding to was the comments around, are we allowed to publicly post our rates in our own website? And that is something that in the CCO website, which is the last sentence, that the CCO shall make this payment model grid publicly available, which is in the last sentence. Then we were responding to say that that's something that we would have to consult with our Oregon Department of Justice folks to see if that's a requirement. We can ask CCO to publicly just post their payment and what they do. That was the response to that.
So again, to clarify, you were saying that DOJ may need to weigh in on the appropriateness or legality of the grid being publicly available?
No.
So I'll speak to that. That was actually me that spoke, and I think that the level of clarity that's been provided in this conversation was that this is a guidance document. I seek that clarification from Mohammed, that it would not be plan-specific reimbursement rates. Is that a correct statement, Mohammed?
Yes.
Okay. So as that discussion emerged, it sounds like there would be nothing, and perhaps this helps inform the rest of the conversation and worth repeating. It sounds like it is the intent of this program that it would not require the posting of plan-specific rates. Is that a correct statement? Does that help address any uncertainty around that?
Okay, thank you.
Sure. And let's go to Yetu.
My question...
And I'm going to ask your organization, sorry?
Yetu with the Home Care Commission.
Thank you.
My question regarding the grid was,
when it comes to fee-for-services. I think like Angie said, she mentioned a little bit about fee-for-service and how that play out with the intensity of the services. So I wanted to reiterate on that again, because with a lot of the systems that we're working is totally different from what a lot of the traditional health workers actually do on the ground. So a typical example is if I take someone to the hospital, I am going there as sometimes as acting into a role with that specific person. I'm wondering how would that person be paid as a traditional health worker? Is that taken into consideration, or is it like a flat fee of taking someone to the hospital? If that makes sense.
Thanks for the comments. So generally, I think this whole payment notion that I want to clarify again is pay the individual THW providing that services however you think is effectively and supportive to that THWs for the longer term with sustainable payment. If you do value-based payment, you do other forms of payment that you do foresee there's a value. And I want to reiterate, we're talking about, bottom bread, people who do this work from bottom up, that really impact health on individuals. And so if you as a CISO value that this contributes ultimately to reducing, high utilization, many other things THW do, then that payment should not be dictating whether they go 2 rounds to the hospital or not, however you pay. But we're not diving into that. We're not diving into plans payments here. We're diving into generally saying pay for THW services that you're going to be rendering within your CCO with a sustainable one that supports the THWs as a workforce within your system. That is the intent here.
Okay, real quick, by show of hands, we're first going to recognize Tony, who asked to speak, and then we're going to recognize Iris, who had her hand up before that. I also need to be mindful of our participants on the phone today. We are giving everyone in the room, obviously, kind of a freestyle approach to speak just in a respectful order. I want to make sure we give folks on the phone the same opportunity. So anyone else on the phone that does want to speak to this, just say your name only, please.
Sandy Sampson.
All right, Sandy, we're going to put you in the queue after Tony, after Iris, and after Angie. Before we give phone off to them, I'm going to make one quick deviation from this. People that were with us at the beginning, we did solicit to see if anyone would want to do public comment. There were no requests. We had a couple people join in the room in the back of the room, and I don't know if others have on the phone. So I just want to pause and take temperature and see by show of hands in the room if anyone would wish to offer public comment, or anyone on the phone as a member of the general public that would wish to do so. If you would state your name at this time. All right, hearing none, we're going to go to Tony, Iris, Angie, and then on the phone, I believe, Sandy, in that order. So if you raise your hand, I will make eye contact with you to put you in the queue, but you will not go before any of those stated individuals. After Sandy on the phone, we will recognize Bruce Thompson. All right.
Yeah, I just wanted to circle back around to Jeremiah and say the intention of this is not to restrict a CCO's ability to terminate a contract with a provider at all. That's not it. We want you to have the latitude to contract with the best providers possible, but the intention is to ensure that payment models or contract concepts are developed in a way that are attractive to community-based organizations and that are not, pilot projects, so to speak, if that makes sense. To say, hey, we have these payment structures, we're trying to really utilize and onboard traditional health workers. That was it.
All right.
So I think the language should reflect that and take into their concern.
Tony, thank you for that comment. We're going to recognize Iris Bixler.
Iris Bixler, Cornerstone Community Housing. I just wanted to bring to everyone's attention that many worker types have done statewide needs assessments. And so if you can put your attention on some of those needs assessments, I think that will answer a lot of your question around sustainability. I have a feeling that we will be sure that those needs assessments are posted online, I hope.
They are available right now on our website. Some of those needs assessments are available publicly on our website.
So I think, again, some of the questions around sustainability can be answered with some of those needs assessments.
Thank you for the comment.
Thank you for that. We're going to go to Angie, then Bruce in the room, then Sandy on the phone.
This is Angie from Orchwa. Just to clarify, Mohammed, there was something you said that almost made it sound like you were talking about reimbursing traditional health workers as individuals directly, which does happen sometimes with doulas, but, and colleagues forgive or correct me if I'm wrong, but I think that's a pretty rare model where usually payment goes to the employer of the traditional health worker. So that could be a peer-run organization, a clinic, or other community-based organization. Just wanted to clarify that.
Thank you for the comment.
Thank you, Angie. We're going to go to Bruce Thompson.
Just in support of the notion of sustainability and workers are important in saving the CCO money. I will talk just briefly about, and I know this is not a typical traditional healthcare worker, but a home care worker. So individuals who have home care help, the quality of the person and the intention of the person to remain in their job is a very significant factor in how often that client will end up in the hospital. And I'm speaking to this from personal experience. So the sustainability of it and recognizing the value to the CCO of having people like traditional healthcare workers doing their job so that they stay at their job, so that they continue to contribute to the health of the community, is a value that hopefully CCOs will find a way to sponsor and to sustain. My comments.
Thank you, Sandy. Hold on. We are going to go to Sandy from the Yellow Hawk Tribal Health Care Center, and then we will recognize Bill Buska and or Jeremiah Rigsby. All right. So, Sandy.
So I know he's saying that we're not looking at the payment methodology, but is all CCOs required then to have either a subcontract or a contract with whether it's a community-based organization or a clinic, or do they employ their own traditional health workers? I guess I just want clarification on the requirement of an organization to provide those services.
To respond to that, it would be both. So the payment model we're talking about, however the CCO deploys that to integrate and make THWs part of that, whether you subcontracting with a community-based, a county health department, or a social service agency. As far as those social service agents are reporting to you, hey, we hiring this number of THWs within our provider network, then the payment basically trickles from CCOs to that social service agency or this community-based organization, and then you just report and share in that. We're not saying you have to hire a bunch of, if the CCO chooses to directly employ THWs and pay them within their network, that's up to them. If they choose to subcontract, that's also up to them. But it's having some form of existing payment within that structure, within your CCO, and delivering, through THWs. That's the intent, yeah.
So with that said, I have just one. So when the CCOs are actually signing contracts with OHA in regards to that payment methodology, is that available for knowing what services they're providing within that CCO contract? Is that public record, I guess?
I'm not clear. Can you maybe paraphrase again? Sorry.
So if I have EOCCO in Eastern Oregon, and I'm looking for a traditional health worker that maybe we don't have at Yellow Hawk Tribal Health Center for services, because they are they're not fee-for-service patients. They're in the CCO. They come to my clinic and they're looking for services, but we can't provide that because they're EOCCO. They're under a care coordination service. Where can I find that information on that particular service if it's not available here to assist that patient?
I think you kind of alluding between services that the tribal provide versus CCOs. I think that's a whole other conversation that I'm happy to talk with you offline. But in terms of the payment model grid or the payment model, that would be something that will be publicly available. And if, let's say, Yellow Hawk consults and contracts with EOCCO to provide that gap of that services that you see all the time, then that's something between you and EOCCO can develop a payment within that and employ to address the traditional health worker services that goes a gap in there. But that's something I think we may have to talk offline a bit.
Okay, I'm going to give opportunity for Bill or Jeremiah as they had requested to speak, and then I'm going to close discussion on this piece. Again, recognizing that participants will have ample opportunity to submit additional comments in writing. I'm basing that decision on the fact that it is 5 minutes after 11. There were 4 elements to this rules. We are 3/4 of the way through it. By that logic, I anticipate a good conversation on item number 4. I want to make sure that we reserve appropriate time for that. So, Bill, go ahead.
This is Bill Bushko with IHN. Actually, a compliment to you, Ralph. When we first sat down, it's like 1-page rule. This isn't going to take us 2.5 hours. But I think that points to the difficulties in this rule, the difficulties the way this rule is written and how it's understood. You can see every one of us has had questions about what does this mean, and I just don't know that this rule as drafted is even close to being something that you would want to submit. And so I would recommend that you really go back and look at how this rule is written, the clarity or lack of clarity, and all the questions that we all have about it. What does it mean? I don't think this rule is ready yet to be in the context. It's just because of every one of us has had questions. What does it mean from the different chairs that we sit? So that's just a comment about the rule as it's drafted today. It's not ready. But I also want to say from IHN CCO perspective, I'm getting the sense that that there's a feeling in the room that the CCOs aren't doing anything around traditional health workers and aren't doing one of the first, there's 2 subcommittees that we started when we started as a CCO. One was alternative payment methodologies and the second was traditional health workers. We gathered all our community partners around to help us figure out how do we increase traditional health workers. We now have over 150 certified traditional health workers. In our 3-county region, we serve 54,000 members in our 3-county region. We have a big workforce. It's growing every day. We're doing a lot to support it. We have in relief nurseries, in schools, in housing organizations, in primary care, obviously, in recovery centers, and working with doulas right now in our area and helping them get certified. We've developed a training hub so that traditional health workers don't have to come to Portland to get certified. They can do it here in our region. There is a lot going on, and I just don't think this rule of all the work and the importance of it, totally agree with Bruce, just really reflects the work that's going on and acknowledges it.
Shelley, do you want?
Jeremiah with Care Oregon, completely agree with Bill's comments and really appreciate the personalized story about the value of people doing work in homes and in the community and what that means. And I want to be clear that we recognize that. When I go, I think when we show up for rule of measure community and we're putting something in statute, it's really trying to deal with the issue that you brought up, which is if I'm taking someone to the hospital, what should I get paid? And I'm like, well, what's the sustainable rate for that? Do we just hire you on in the CCO? Do we pay you for that individual service, which is fee for service? Do we work through a community-based organization? To answer those questions, we would want to have rules like this come out of conversations back and forth between probably CCOs and traditional health workers to figure out what's that. And I don't want to be coy. I don't want to say like we need a blue ribbon commission to take another 2 years to make legislative recommendations to have another blue ribbon commission. That's not what I'm saying. But what I am saying is I think there's a way to get at the intent that doesn't presume we know why 4 CCOs have traditional health workers after 5 years. I think we want to get at something that recognizes that each region has different infrastructure and there are reasons why CCOs use them and don't use them. And if there's a place we're trying to go, let's talk about how to do that serves the issues we're seeing on the ground, as opposed to just academically saying if we can do these things, then A, B, and C will happen. Because I think what you're hearing from us is we're not sure that it will.
Okay. Jeremiah, thank you for that. I want to remind again, so first we appreciate the honest feedback of both the process and the substance of the rule. I think it's been illuminated from a number of people today that there is some work to be done here, and that is our intention to do. To that point, as I said before, and the opportunity for you to offer follow-up comment, that follow-up public comment may include proposed rule language. I want to make that clear. So if there are people, there's a lot of passion in this room on this subject right now. So to that point, regardless of where you come from and what your position is on that, you are welcome and encouraged in your submission to us to include what you believe might be appropriate language. We will take that under advisement. For that, we thank you. I am going to move us along now to the last item. That is number 4. CCOs shall designate a THW liaison who shall serve as the central point of contact for the THW integration. May I first get, by show of hands in the room, who will wish to speak to this? I'm seeing 1, 2 thus far. Can I hear just by name only individuals on the phone that will wish to speak to this? Folks on the phone, it will be your turn to go first. All right, hearing none, let's start on this side of the room. Who did we see? We'll recognize Athena Goldberg from All Care Health.
Okay. I guess my concern with this added into the rule is that I understand its intent, but we have behavioral health. We have a lot of different ways in which we use traditional health workers, and I think just sort of looking at it as one person who is going to navigate all of those systems might limit its operationally being functional, and that would be a concern. I wouldn't want it would almost create another subcategory rather than making it a system-wide change.
Thank you for that comment. Mohammed or Shelley, do you wish to?
Yeah, and I think in particular that number 4 and as well as the other languages in the rule presented here, these were what was in the RFA as well as in the contract right now. And the intent of this THW liaison is someone who's going to coordinate all THWs within your system. Not like someone who's a THW doing THW work doing this. It is one person helping all THWs integrate the system within your system of care. That's like the main central person. And one other thing I will also reiterate would be that in regarding to changes or things that or technical expertise, that's why we would be always encouraging the commission is available to support CCOs to really support them implement this, as well as there are a lot of associations, organizations out there that do provide technical expertise to make sure this is implemented and supported for the CCO's integration.
And real quick, I want to add on to that, and again, and for those of you that have participated with us throughout this week in this process, I want to note that the agency has taken a lot of credence in trying to hold to the fidelity of Oregon Health Policy Board recommendations. With that said, I want to note specifically in this policy board recommendation in year 1 that the CCO designates a single point of accountability for that role. So I just want to note and recognize publicly that we are really trying hard to maintain fidelity to the spirit and intent of those recommendations. So we will go to Angie next.
This is Angie from the Oregon Community Health Workers Association. I would like it to be rephrased to say CCO shall hire a dedicated THW liaison staff, because I think you could interpret this as you could have an existing staff who's tagged as also in their many job responsibilities as the THW liaison, and I think that this is at least a one full-time staff job. And I think we should add that this position description should be informed by recommendations issued by the Traditional Health Worker Commission.
Thank you for the comment.
And other individuals will come back to Iris. Before doing so, can I just do a check-in on the phone to see if anyone else will wish to engage on this? All right, Iris, go ahead.
Yes, Iris with Cornerstone Community Housing. I just wanted to clarify, is the THW liaison position intended to be by region or by CCO? So will a CCO that's in multiple regions be required to have one THW liaison within their CCO per region, or can they be in multiple regions for one position?
So I think we had back and forth on this issue, and we just don't want to say one size fits all approach that. You know, some CCOs have smaller regions, some have bigger regions. At the initial ask now is to create one position that can coordinate the support of integration and utilization. Wholeheartedly, if a CCO has like 14 region or 12 region and things like, you know, this work might not be able to be coordinated by one person, and then they choose to hire 2 more or 3 more, that is up to them. But we just, for the meantime, just want to create as one person for the CCOs to really be, you know, a central point of contact.
And I guess, this is Iris again, I guess I ask because I worry that if a CCO is in multiple regions and they only have one traditional health worker liaison, that person doesn't know about the community in which they aren't embedded. So I wonder if there should be some conversation about how we recommend this position be regional.
Thank you for the comment, but at the moment we're only asking for one position for CCOs to provide at the moment. And if they go further down, like to hire, we're not restricting. This is a starting place. We all talk about improving para health products. So if the CCO chooses like, well, with our region, this is one part, 150 is not, or one position cannot support this work, they can expand it as they need. Thank you.
Thank you as well for that comment. We will recognize first Letitia Dumas, and then we'll go down to Netu, and then I see Robin Traver, in that order.
Lakeisha Dumas, Traditional Health Worker, Chair, and Multnomah County Mental Health and Addiction Services Division. I just want to say in 4, maybe stating a minimum of 1, so it opens it up for those who can expand, but a minimum of 1.
Thank you for that comment. We'll go to Netu.
Yet with the Home Care Commission. Another thing that I would like to be clarified in this one is clarified that that person, the liaison, is not going to be the one who is doing the THW work. In the sense that your duty is going to be the connection, not, you know, doing a job of maybe a community health worker or a traditional health worker or any of the other type. So to differentiate that way that person is not overloaded with work or doing whatever that person is not being hired for. So maybe some clarity on that would be good.
Thank you. At the current language in the contract, it kind of states like what are the different roles that this THW liaison can play, as well as the rule is here, but the language in the current contract that explains what are the different tasks that we anticipate this person would play. And thanks for the comment.
And we will go to Robin Traver next.
Robin Traver from Umpqua Health Alliance. I just wanted to advocate for not specifying the FTE requirement. I think just keeping it as the language is now is something we would be supportive of. I'm not saying it, this isn't particularly my wheelhouse, so I apologize, but you know, and it may be something that does require a full FTE. I hesitate to have that in OAR. This has been addressed at previous RACs throughout the week, and OHA has stated that, you know, they're not going to put words like dedicated into other language and other OARs, so I'll just advocate for the same piece here.
Thank you for that comment. Are there any other comments before we close? All right, so we appreciate everyone's input today very much. I do want to give both Shelley and Mohammed opportunity for some closing remarks. We really appreciate all the work that has gone into this and developing this. We recognize too that there's still a good amount of work to be done. So with that said, I want to give them both opportunity to offer closing thoughts or remarks.
Thanks again, Ralph, and everyone else who have participated in this group throughout the RAC process, those on the phone as well. We do want to emphasize that this is, as you see, it's a new role. So we want to always offer opportunities for rooms and changes that needs to happen in regards to making this effective and smoother for both the workforce as well as for CCOs and for everyone else in support with the commission work and our office. We just want to reiterate that this is not like a one-end thing, that other additional comments you submit, other additional changes you propose into the rule language would be helpful. That way we are having a robust, well collaborative effort of both that CCO are fully on board, as well as we are supporting with all the technical expertise that they need to really implement. And our office is always willing to provide any technical assistance in regards to THWs, with the support of the commission, and also connect you with all community-based organization or association that do this work professionally for each workforce, so that you can contact with them or get more support of technical assistance you may need as a CCO. And thank you again for participating.
Thank you all for your comments and feedback, and we are going to take into account all your feedback and comments, and then working closely with the Traditional Health Workers Commission, we will look at the rules and rule language, and then making changes if they advise us to make changes. And also, just a reminder, as Ralph said, that these rules are based on the policies which were approved by the Oregon Health Policy Board. And the policies, the one unique fact about these policies, on which this rule is based, actually not developed by us, by the OHA staff, but by the Traditional Health Workers Commission. And also it preceded CCO 2.0 work. They developed and proposed these policies in 2017, much before we started our CCO 2.0 work, based on their experience working with the CCO and within the health system, and based on their experience about the barriers that they were facing at that time. The Traditional Health Workers Commission developed these proposals and wrote a letter to Director Pat Allen. And those policies, we have developed these rules based on those policies that came from the so-called horse's mouth, because they are the subject matter expertise and they are working at the ground level, at the grassroots level, at the community level. So I just wanted to recognize that part of Traditional Health Workers Commission.
Shelley and Mohammed, thank you both for that. Members in person on the phone, again, we thank you for your active participation today. Members of the general public in the room and on the phone, we appreciate you joining us. Thank you all very much. This concludes this Rules Advisory Committee.